Hello, I'm Ed.
And I'm Johnny.
Welcome to episode 10 of the surgical discussion series on surgery. This podcast is on breast disease. During this podcast, we're going to consider the important clinical anatomy of the breast. We're going to talk about some of the principles of investigation in breast disease. And then we're going to go through the various pathologies affecting the breast, particularly benign breast disease and, very importantly, malignant breast disease. So, anatomy of the breast. Over to you, Johnny.
Okay. So the breast is located between the second and sixth ribs, and the underlying muscle is 2/3 on the pec major and 1/3 on the serratus anterior. It's made of fat, which composes most of the bulk of the breast.
It's actually a large sweat gland, the breast.
Yeah, modified.
Modified, yeah.
And in the fat are 15 to 20 lobules.
Okay, and there's a hierarchical duct system, isn't there? There's these TDLUs, these terminal lobular duct units, which are the smallest units, and they're like little acini coming off central duct. And then this goes into extralobular ducts and then major ducts, which then open onto the nipple.
And here you can see it. So you've got the nipple, and around that the areola, which has lots of Montgomery's tubercles, which are much like sebaceous sweat glands.
Yeah.
So the blood supply, there's three main arteries supplying the breast, which you can see in this picture. The axillary artery, the internal thoracic artery, and then into perforators, and the intercostal artery, which isn't a large part of the supply.
It's quite small.
And the venous supply follows the arterial.
Yeah, as shown, yeah.
And there's also three lymphatic channels, those that go to the axillary lymph nodes, the internal mammary, which are deep and on the mediastinum, and the supraclavicular.
Yeah, and this is very, very important to remember, particularly for staging of breast malignancy. And the only way of assessing internal mammary nodes is to do a CT scan. We'll get to that later, though.
Okay, and on clinical examination, you need to feel all the groups of the axillary lymph nodes. So these are the anterior, posterior, lateral, central, and apical nodes, which you can see shown on this picture.
Yeah, very important. Okay, I'm going to talk now about some basic principles in the investigation of breast disease. In this podcast series, we haven't really spoken at length about particular features of histories and examinations for each system, and I'm not going to do so here either, but I think it's important to have a basic idea of some of the common changes that occur in the presentation of this disease. So, first of all, it's very important to understand the notion of triple assessment. Now, this is used in lots of different areas of surgery, but it's particularly relevant to breast disease. Triple therapy involves three components: clinical assessment, which consists of a good history and a good examination, radiology, such as ultrasound or mammography, and finally, fine needle aspiration cytology, which is commonly abbreviated to FNAC. So, in terms of basic history, you're going to go through your standard history-taking procedure. In the presented complaint and history presented complaint, you're particularly interested in lumps. You want to know all about lumps, when they appeared, when they're getting worse, if it's around the types of periods, etc.
Whether it's painful or not.
Whether it's painful, that's the next thing on the list. Yeah, very important. Changes in pain. Nipple discharge. And if there has been nipple discharge, is it bloody? Is it cheesy? Is it... I don't know, can you think of any more nipple discharges?
Purulent.
Purulent, yes, absolutely. You also want to know about associations. So is there been any recent change in the breast itself? Is there any skin change? Is there any nipple retraction? And obviously you want to look for features of metastases. So has the patient lost weight recently? Have they been particularly fatigued, or do they have bony pain or tummy pain? In terms of the past medical history, you want to find out about any previous breast problems, and you also want to take a full gynecological and obstetric history to determine women's estrogen exposure, because certain patterns of gynecological and obstetric history are associated with an increased risk of breast malignancy, but we'll talk a little bit about that later. Family history is extremely important, both in terms of the actual genes, the BRCA genes, and also in terms of relatives. And then finally, drug history, and this is really about exogenous estrogens, either administered via the pill or through HRT. Okay, examination. And we're not going to spend a long time going through examination. This is something you should be doing on the wards and tutorials and stuff like that. But remember, it involves an inspection phase with the patient positioned on the side of the bed in various different stances, so hands on hips, behind head, etc. And also involves palpation, both of the breast itself, all quadrants of course, and then to other sites such as the nodes, as we spoke about earlier. You need to percuss on the back for bony tenderness, and then feel for hepatomegaly. This is just a slide showing some of the more common breast changes that women notice and that one can see on examination of the breast, inspection particularly. Lumps, skin dimpling, a phenomenon called peau d'orange, which represents infiltration of the subcutaneous tissue, particularly the lymphatic channels. There may be a change in the skin colour. The actual tumour may even ulcerate to the skin surface. There can be actual distortion of the nipple, either an eczematous reaction on the surface caused by Paget's disease, or displacement of the nipple, or inversion or prominence.
It's important to know whether it's normally inverted or not.
Yeah.
Some people have inverted nipples.
Yeah, so you need to ask about that. And obviously there can also be a discharge, as we mentioned earlier, and it's important, or you might want to ask, particularly to the lady during the examination, to try and elicit this discharge. Okay, in terms of the second phase of our triple assessment, there are two modalities that are of use, ultrasound and mammography. Ultrasound tends to be used as the radiological investigation of choice of a breast lump in those under 35 years of age. And this is really because the breasts of younger people are more dense and therefore not suitable for mammography. In older patients and in breast screening, particularly, mammography is used, typically two views, the oblique and the craniocaudal, but it's important to remember that this has a 10% false negative rate. The last phase of triple assessment involves cytology plus or minus biopsy. The fine needle aspiration cytology, FNAC, as we said earlier. What does that involve, Johnny, doing that procedure?
With local anaesthetic,
yep.
First, infiltrate around where you're going to place the needle, and then put the needle in, possibly under ultrasound guidance, yeah, and then pass it about 10 times through, aspirating.
Okay. And then basically it's a cellular diagnosis. So you get the cells out and you look at the cells for features of malignant change, things like dyskaryosis and mitotic figures and stuff like that. It's fairly easy to do, as Johnny's just described. It has a fairly good sensitivity at about 95%. Obviously, if the cytology is positive, then you need to move on to further investigations. But sometimes it will come back as being an unsure result or a mixed pattern. And then you also need to think about moving on as well. And the investigation of choice is a core biopsy, a true cut biopsy, as this enables you to obtain a histological specimen to determine the exact diagnosis and also to get estrogen receptor status, which is very important in terms of treatment.
So, the benign breast diseases. We can divide this into congenital diseases, developmental, or acquired. And these can be further split into hormonal, infective, inflammatory, or benign tumours. So firstly, congenital. So this can be amastia, so the absence of both the breast and the nipple.
It's also known as Poland syndrome.
Really?
Yeah.
Why is that?
I have no idea. Mm-hmm. But there we go. It's just called Poland syndrome. I don't know if it's more common in Poland, but okay. Or there was a guy in Poland who described it first. I don't know.
Maybe.
Could be either.
And there's also hyperplasia. And most women have a degree of hyperplasia, one breast being larger than the other.
Yeah.
But obviously you assess the extent of this hyperplasia.
You don't want it to be too much.
And finally, there's accessory nipples. So this is the failure of the milk line to regress. And so the nipples, accessory nipples, are found in the milk line, which runs
vertically,
yeah,
down from the nipple.
Okay. And if these are problematic or painful or anything, then they can be excised.
Or cosmetic. People.
And here we can see some amastia of the left breast and nipple, and also an accessory nipple.
I think that's probably a man.
I hope that is a man.
I hope that's a man, yeah.
Okay, acquired disorders. These can be divided. Firstly, hormonal, and these tend to be cyclical. So there's benign mammary dysplasia, which is also known as ANDI. What does that stand for?
ANDI, yeah, it stands for an aberration of normal development and involution. And it's a term first coined at the Cardiff Breast Clinic, which is a great centre of breast research. And basically it represents various aberrations, as the name suggests, in development, such as fibrosis, adenosis, cyst formation, papillomatosis, and things like that, and is certainly very common.
Okay, so it tends to be found in premenopausal women, and they present with a painful nodular lump, most commonly in the upper outer quadrant of the breast.
Yeah, and that's actually the quadrant. The upper outer quadrant is the most important quadrant in terms of lumps.
Where lumps are found.
Yeah.
And treatment, as always, can be conservative or medical or surgical.
Mm-hmm.
So conservative treatment will be analgesia and evening primrose oil. I'm not sure how that works, but
I don't think anyone really knows how it works, actually.
Okay.
It's recommended for lots of things.
Medical treatment with tamoxifen or bromocriptine, and finally, if it's causing a lot of pain, you can excise the lump.
Yeah. Another thing we didn't mention actually is wearing a good bra. That's very important as a conservative measure as well. Some women, don't have fitted bras properly, and that causes problems.
Okay, great. So if there's any suspicion of malignancy, then you would need to do a FNAC. Second hormonal disorder is cystic disease, and as this says, it's cysts in the breast, more common in women approaching menopause, so 40 or 50 years old. And obviously on examination, you would maybe find transillumination of the cysts, and with aspiration, they may have green or brown fluid. If there is any blood or it persists, then you may need to go into fine needle aspiration cytology and ultrasound.
Yeah, that's important because you don't want to miss
malignancy.
Yeah, exactly. Especially in that age group.
The final hormonal disorder is the fibroadenoma, which is one of the more common ones.
A breast mouse.
Yeah. So this is common in younger women, often between the ages of 15 to 40, and they present as smooth, firm, mobile masses. You can occasionally have more than one.
Mm-hmm.
You can see a picture here, so it's rounded.
Mm-hmm.
And they can be divided into pericanalicular, which tend to be hard and white, or intracanalicular, which are large and soft. Normally, these follow the cycle of the woman, so tend to enlarge and then disappear at certain points during the cycle. But if it's very large or there's any malignant change, then you may need to excise the lump.
Yep.
So infective causes, these can be split into those associated with lactation and those associated with no lactation. So lactational mastitis tends to be when women are breastfeeding, and breastfeeding causes trauma and there's a cracked nipple, which may then become infected with staph.
Yep, so a point of entry leading to staph infection.
And complication of this or any mastitis can be formation of an abscess, and this can be drained and possibly treated with antibiotics.
Certainly can.
Non-lactational mastitis, this once again is usually caused by staph, and this can cause periductal mastitis, so the infection goes down into the duct of the breast, and this tends to present with mastalgia, so breast pain, purulent discharge perhaps, and nipple retraction. And both of these can be treated with a obviously conservatively with analgesia for pain and antibiotics such as fluproxacillin.
Yeah, for the staph. Yeah. There are a couple of other causes of non-lactational mastitis, which aren't on the slide. Things like TB can cause it, syphilis, acylletomyositis.
Okay, inflammatory disorders. So you've got duct ectasia. This is when, like bronchiectasis, there's a dilatation of the ducts.
Good analogy.
Thank you. And this produces a cheesy blood-stained discharge, which sounds rather nasty to me.
It's pretty unpleasant, really, isn't it?
Mm-hmm. And finally, fat necrosis. So after trauma, maybe in a road traffic accident.
Very common. Breast versus steering wheel, not a good thing.
Mm-hmm. Always going to come off worse.
Yeah.
So the trauma can then lead to fibrosis and calcification, and this may progress to cancer. So you may want to investigate that fully. Okay.
Yeah.
And finally, the benign neoplasms. I'm sure there are more, but we're just going to talk about duct papilloma and lipoma. So duct papilloma is a benign tumour inside the duct of the breast, which you can see here. Occurs between 35 and 50 years. And once again, this presents with blood-stained discharge and can be treated with microdotectomy, which I'm not sure.
I think it's just
removal of the duct.
That duct, yeah.
Or a complete excision of the duct.
Okay, that's what I thought microdotectomy was. Anyway, never mind.
And also tumours of the fat, as we said.
Yeah.
This is mainly fat, so lipomas.
Lipomas. And those can just be cut out.
Okay. Breast cancer.
Yeah, breast cancer. Okay, so this is going to make up the majority of this talk. In terms of the epidemiology, I think we all know that breast cancer is a fairly common condition. It affects up to 1 in 11 women at some stage in their life. It increases, there's increased risk with age, and it's a particular problem in the West. As always, we like to divide up our risk factors. So lifestyle, alcohol, high saturated fat diets have both been associated with breast malignancy. As intimated earlier, it's very important as part of your history for breast disease to have a extensive gynecological and obstetric history. One of the reasons for this is that there is an association with prolonged high estrogen exposure and the development of breast malignancy. So you want to know when the girl first had her period and when the menopause occurred. And obviously, the earlier the first period and the later the menopause, the more risk you're going to have of breast malignancy. As also said earlier, you need to ask about exogenous hormones as well, such as the pill and HRT. In terms of family history and genetics, having breast malignancy in a first-degree relative is a very high risk for the development of malignancy in that person, as is certain genes. And these genes, the BRCA1 and BRCA2, these have a dominant inheritance, and the BRCA1 is also associated with ovarian malignancy. The final risk factor is having a first child over 30 years. Okay, so there are lots of different tumour types. From a epidemiological point of view, the most important ones to be aware of are ductal and lobular. And these both go through non-invasive carcinoma in situ phases before they become invasive. Other ones just to be aware of and have at the back of your mind are medullary carcinomas that occur in younger patients, colloid or mucinous tumours that occur in older patients and can look benign on a mammogram, and papillary tumours. And then finally there's Paget's, which is really a disease of the nipple. It looks very much like eczema. And the important thing is if there's eczema of the nipple, which can happen, not normally, but in a benign process, if it persists for longer than 2 weeks, you need to investigate for underlying malignancy. Okay, we spoke a little bit about this earlier, but just to clarify, the most common site for occurrence of tumours is in the upper outer quadrant, 45% will occur here. And the next common, or most common site is the areola area, where 20% will occur. Okay, investigations. Remember your triple assessment, which is composed of a clinical evaluation, radiography. If it's a young person, remember ultrasound. If it's an older person, mammography. And then finally, biopsy and cytology. There are two staging systems that are currently in use. These are the clinical and the TNM. So here we go. This is just a basic clinical staging system. In stage 1, or early disease, the tumour is confined to the breast, as shown here on the diagram, and there are no nodes. In stage 2, representing also early disease, there is some spread to the ipsilateral axillary nodes, and these are movable. In stage 3, representing locally advanced disease, the tumour has spread to the superficial structures of the chest wall, so will move when the lady goes through a different movement on the inspection phase of the examination. And there's also involvement of the ipsilateral internal mammary lymph nodes. And this will probably have to be detected on CT. In stage 4 disease, there is advanced, usually metastatic disease with metastases at distant sites. And the most important distant sites to be aware of in the context of breast disease are the liver, the bones, and the lungs. Okay, I'm not sure that you'll have to actually know the details of the TNM staging system, but basically the tumour can be classified according to its size and the fixation, whether it's to the skin or to the underlying pectoral muscles. The nodes, just like in the clinical staging system, can be graded whether they're ipsilateral mobile, ipsilateral fixed, or involving the internal mammary. And then with METs, you simply, as always, say there are no METs or METs present. Okay, principles of treatment. We can divide the treatment into that for early disease and that for advanced disease. It's not always so easy to distinguish between these, and distinction will be based upon things like the age, the stage of the tumour, fitness for surgery, and of course the patient wishes. What is important, however, to know is that the MDT is, as always, very important in assessing these patients and the best treatment modalities to be used for them. So tell us about early disease treatment, Ron.
Okay. Main aims are to treat the local tumour.
Okay.
To investigate the extent of the axillary involvement and clear that.
Yep.
Prevent recurrence, and then to do reconstructive measures.
Mm-hmm.
So local treatment, got two options, and these are wide local excision with radiotherapy, or removal of the whole breast with a mastectomy. And mastectomy is indicated in large central masses, or if the patient is unable to undergo radiotherapy. Mm-hmm. Both these have the same survival, but there's less recurrence with mastectomy, obviously, as the breast is being removed.
Mm.
The axillary management, firstly, you've got to assess the extent to which it's involved, and then, obviously, if it is involved, you've got to remove the involved lymph nodes. So assessment can be done with axillary sampling. This is when they take some of the lower axillary nodes, mm-hmm. And check to see whether they are involved. Usually they remove 4 nodes, I believe.
Okay.
And a newer method is sentinel node mapping.
Yep.
And this is done during the surgical procedure. So they inject a radioisotope, and they see whether the first or the sentinel node is involved, and if it's not involved, then it won't have spread any further down the chain.
Yeah, that's a modern technique.
Yeah. And finally, then there's treatment, and this involves clearing the involved lymph nodes, and it can be done at 3 levels. Mm-hmm. So level 1 is below pec minor. Level 2 is behind or underneath pec minor. And level 3, which is a total clearance, is above pec minor.
It certainly is.
So you also need to prevent recurrence, and you've got 3 main options. This involves radiotherapy, chemotherapy, or hormonal treatments. So radiotherapy can be used after a wide local excision, as we've already said, to treat the axilla, or in palliation of metastases, such as in the bone. Chemotherapy, there's no guidelines as to when this is used, but it's more commonly used with recurrence, in large tumours, or in younger women who are premenopausal.
Yeah.
And finally, there's hormonal treatment using tamoxifen or the newer Arimidex.
The aromatase enzyme. Yep.
And this is dependent upon the estrogen receptor status, which we've already mentioned. So you tend to use tamoxifen if they're positive for this. However, has been shown that in some postmenopausal women, it's also useful.
Yeah, even if they're negative.
Yeah.
Up to 15% of estrogen receptor negative females will also respond to tamoxifen.
Okay.
Yep.
And finally, we've got the reconstructive options following the surgery. So we've got the tram flap.
Yep. Which stands for a transfer of rectus abdominis myocutaneous flap.
Yeah, so this is after a mastectomy. You need to get some more tissue up there so that you can reconstruct the breast, so counteracting problems of low self-esteem, depression, and
psychological aspects.
Yeah. And you can see how that is done on this little picture here. Other options are latissimus dorsi flap. This involves cutting the lat dorsi and then swinging it round to make up more of the breast. And you can see here, it only leaves a small scar around the nipple. And other options of reconstructive management are things such as implants, so saline or silicone, and also replacing the nipple possibly with a tattoo.
Yeah. And in terms of reconstructions, the tram flap option is thought to be better for people who are slightly overweight.
Okay.
So, advanced disease. Shall I talk about this?
Yeah. No, you can continue on your merry way.
So the first line treatment of advanced disease is tamoxifen. And then the other things that you use really depend upon the situation. For some patients, clearly, you're going to be palliating them. I mean, their tumours may be very far spread. They may have a very advanced stage. Therefore, for these patients, you're going to be giving them treatments for metastatic disease, so bisphosphonates for bone involvement, steroids for cerebral involvement, obviously important levels of analgesia and pain relief, stuff like that. And obviously, you need to develop some sort of support package as well. Also, in advanced disease, you can consider therapies for local recurrence, so you can perform re-excisions and radiotherapy. But generally, this is a fairly dynamic and adaptive process, and you employ different modalities of treatment depending on the situation and after discussion within the multidisciplinary setting. So, complications of breast surgery itself. As always, you can divide complications of surgery into immediate, early, and late. The immediate ones are general complications of surgery, so that is complications of the general anaesthetic, hemorrhage, and in particular breast surgery, obviously, because the lungs are fairly close to the chest wall, pneumothorax is quite common as well. Important early complications are infection, hematoma, and seroma. Seroma, what is that, Johnny?
That's an accumulation of tissue fluid in the axilla, I think.
Yeah, I think it is. Not really sure. Well, I suppose if there's been axillary local trauma, axillary clearance and stuff, could be why. Yeah. And then finally, late complications. People can get frozen shoulders. Lymphedema is very common in the arms, and this can be treated with elevation and support stockings. And then finally, nerve damage, and the particular nerve that tends to be damaged is the brachial nerve. Okay, breast screening, Johnny.
So this has been around since 1988 in the UK, following the Forest Report.
Yeah, put that in your exam. Nice historical bit of detail.
I like that.
And
And it's offered to all women from 50 to 65 every 3 years, although now I think it's been extended to 70 years in some places.
Okay, good.
And they do this with the 2-view mammography.
Yeah.
As we said, that's better for older
Yep, so that would make
ladies.
sense. And you use the views of the craniocaudal and the oblique.
Yeah. And then obviously if anything's found, then that goes on to further investigation with fine needle and things like that.
Yeah.
Also, can I just say that the prognosis is assessed using the Nottingham Prognostic Indicator, where they take into account the size of the tumour, the lymph nodes, and the grade of the tumour.
Yeah.
And that gives them kind of idea as to the outcome.
Okay, thanks. That's good.
Okay, so in summary, we've been through the breast anatomy, quite simply, the principles of triple therapy. Triple assessment is in something else.
No, I think that there's a typo on the slide, actually. That's not triple therapy. Triple therapy is used in TB. Triple assessment is used in this situation.
And triple therapy is used in...
the eradication of Helicobacter pylori.
Indeed, yeah. So anyway...
We're just testing. I was testing you there.
Okay, I failed that one.
You fell into my trap. Yeah.
So triple assessment is obviously the clinical, the imaging, and the fine needle aspiration cytology.
Yep.
Then we spoke a little bit about benign breast disease, about congenital, developmental, and acquired. And then we spoke about malignant breast disease, the risk factors, management, and things like that.
Yeah.
And finally, we spoke about breast screening.
Yeah, and the Forest Report.
Indeed, 1988.
Remember that. Yeah, so thanks for listening. As always, please visit the site and email us if you have any questions. We'll see you next time. It's goodbye from Ed.
And goodbye from Johnny.
Goodbye.